So, as we alluded to a little bit in course 1, there appears to be a timeline that's associated in the transference from acute to chronic pain. Let's take a look at it, and we're going to back up a quick step and take a look at what happens with that acute pain here now that is an episode or an experience of shock. That initial pain is probably as high as we're ever going to feel it with the initial burn, pressure, blunt instrument, trauma, incision, etc. So there's our shock. That happens early in the timeline over on the y-axis, high on the y-axis, and very early to the left on the x-axis. When that pain has subsided mildly over the next minutes to hours to even days, the individual can begin to experience some sadness because they recognize the pain has gone down, they're no longer in shock, but the pain is still there and they had expected it to fully dissipate. After that has transferred into a period of more days or now more than a week, and the pain is still lower, reducing, but still present, the individual can experience some degree of concern due to the persistence. When we have transferred over a week and a half, 2 weeks, again, speaking in terms of generalities on the time frame here, when that pain has continued on and now is staying level but low threshold, the individual can experience some degree of confusion as to why this pain has continued to linger. When this continues on and we're now over a month or perhaps closing in on 2, the individual can see not only that the pain is still there, but additionally, they can experience the loss from the activities that they've not been able to engage in. Those may include relationships, work, avocational, sport-related trips, and the like. So this individual is now experiencing real loss from the direct result of the pain. When we've moved into an area where we can call it definitively chronic pain, now more than 3 months, the individual rightfully has elevated their symptomatology, their perception of the situation, and maybe the pain now, due to its persistence rather than due to its level, the severity of pain, magnitude, if you will, now begins to elevate on their subjective charts. And now they feel angry about this situation, that it has lasted this long. So let's move into this consideration that's directly related, that there is a terrible triad of pain that causes a number of triggers that are controllable if we're attentive to them and if we let them. So we have to be recognizing that people that are in chronic pain are experiencing the triad of suffering, sleeplessness, and sadness. And the ability to be able to manage these starts with the notion that I can overcome, you have helped other people overcome, I am being listened to, I am a viable and important part of my own team to help me get better, and there are some controllable things that I'm not taking current advantage of that will help us get me better. Changes in mood, movement, function, relationships, and treatments that we can accept by trigger management. So interestingly enough, we recognize that in this terrible triad of sleeplessness and suffering and sadness, that the brain is systematically impacted across the entirety of function. And here's something that I promised to you again that we would expand on in course 2, that the brain is suppressed across every different executive, cognitive, decision-making, sequencing, memory, attention, impulse control, all of those executive control phenomenon, as well as every performance feature that the brain is responsible of participating in. So for example, these are some facts of what the human brain is capable of: multitasking, recalling old information. You look at this here, 67,890 digits of pi cited correctly. The brain is dramatically capable when it's not subjected to pain, but when your brain is in pain, the brain is insulted across the primary sensory cortex, the amygdala, the prefrontal cortex. So now we're already talking about fear expectations, decision-making, attention, cingulate cortex with associations, body schema, attention, premotor and primary motor cortex, accuracy of motor control, movement organization, selection, response time, accuracy, fall prevention, cerebellum, coordination, comparison, cognition, episodic memories, and accuracy, hypothalamus, thalamus, regulation of hormones and autonomic expressions, spinal cord, transmission and interruption, modulation, inhibition of descending signals, and then obviously the hippocampus, memory, storage, perception of facts and events. So when we utilize the soft skills to our advantage, we can actually help people begin to recover utilizing an informed, personalized manner. And I bring back to you this letter that I introduced to you in course 1. I'm not going to reiterate to you here again, but take a moment to read this, consider printing this out for one of your patients. It's intentional that it is written to brain and mind together, and that's why it's written to BRIND. Those two are inseparable. They are part and parcel and one and the same. That basically says, okay, I can accept that I'm in pain. Thank you for the signals. This is going to lead me to making more significant changes in my life. And now let's go find those areas.